So I would now like to move on with our IC. So when we diagnose a new myope, we always have a lot of thought process. What is to be done with this particular patient? How we have to progress further? What investigations we have to do? What advice we have to give? So we have Dr. Koheli who will be speaking on and addressing these concerns. The new myope, Dr. Koheli.
So, continuing the IC, we've covered the pre-myope stage. And at the pre-myope stage, we have yet not given the child the spectacles. So, the new myope, why is it the most intense stage of the management of myopia? Because here we are managing the parents' shock, managing parents' expectations, do all the baseline investigations. We have to check the siblings, we have to educate the upstream referrals, we have to explain all the modalities of treatment. We have to help them choose the right spectacles and also allay a child's anxiety of being different and being bullied. And here is why it is the most gratifying stage of management of myopia, because this is where you, as the ophthalmologist, get to shine. You get to be a part of a huge discovery in a child's life, and you get to make mere patients into raving fans and dispel myths around myopia. So the first thing in management was, how was it diagnosed and who diagnosed it first? Was it checked at a school screening or by accident on closing an eye, or was it at a regular checkup at an ophthalmologist's clinic with no symptoms, or was it at an optical store over the counter checkup, which a lot of parents do, or did the child complain, or did the parent notice, or the teacher notice? Now, why is this important? And this takes me to the first management that you will do strategy. The first management strategy would be to educate the first line detectors. So your first line detectors could be school teachers, parents, optical stores, children themselves, on the signs and symptoms, on what to look out for to diagnose that they might have a refractive error. And this is the time to educate them about need of comprehensive ophthalmic checkup, and also educate about unilateral myopia, to be able to check one eye closed. So teaching school children about checking each eye closed. And why is this management option really important? Is that this helps in early detection, initial counseling, affects the entire management of myopia. So who was the first one detecting, and what did they tell them about myopia? If the optical store person tells them that if you wear the glasses your number will go away, then that messaging continues for the rest of their life. So this kind of education to the optical stores themselves is very important at this stage. And then, of course, not missing unilateral myopes, teaching healthy eye care habits in schools. And this is also where we can help in making school policy making, as Dr. Aditya already said, that how the schools are made, how the classrooms are made, what kind of lighting is important, and also outdoor sunlight time. And of course, it increases referrals to you. So the next management step would be the comprehensive evaluation. This is where you would want to do a dynamic refraction and also a cycloplegic refraction, and the difference between the two, teaching them about what is pseudomyopia. This is also where you might want to do a post-mydriatic testing, fundus evaluation, all the biometrics, which includes your axial length, your lens thickness, maybe even your cornea thickness, corneal topography, as well as accommodative lag. This is the basic comprehensive evaluation for every child of new myopia. Why is this management option important? Anterior segment, posterior segment evaluation is important. And also, what is important is that you want to do this comprehensive evaluation after getting spectacles as well. So you're going to do the refraction, you're going to do an A scan biometry, you're going to check the alignment post spectacles. So after 15 days of wearing the spectacles, you want to do a binocular vision dichoptic testing for dominance, because vision is not the same as eyesight. there might be 6/6 vision post spectacles, but you want to see if there is a dominance in one of the eyes, and this is where I would introduce some kind of vision therapy. This is also where you would want to do binocular vision assessment. You also want to do near and far vision separately for myopes, which we don't do generally by general ophthalmologists. And you want to test for accommodation lag and accommodative facility wearing spectacles. There's a lot of difference between testing for accommodative lag without refractive error corrective and correcting it and then measuring your accommodative lag. Why is this important? The changes after spectacle wear is very different, and just because visual acuity is 6/6, it does not mean that both the eyes are seeing the same object, and this is especially true in anisometropia and anisokenia, and this is where there's the difference between a general ophthalmologist and a pediatric ophthalmologist. Now, the next thing is managing parents' emotions, and what I like to call the 5 stages of grief that a parent goes through. These 5 stages of grief are denial. So they will ask, but my child never complained that she cannot see. No one in our family wears glasses. That's denial. Anger. I told him not to see so much TV. The next is bargaining. Doctor, can we give carrots? Can we give carrot juice and spinach juice? The next stage is depression. Now he will wear glasses forever. The 5th stage is acceptance. That is, when do we come for our next visit? So walking a parent through all the 5 stages of grief is where we make raving fans versus just mere patients. This is what I do in my own clinic. We have these Harry Potter badges which we give to each child. The badge is red in color and it says, my glasses are my superpower. They can attach it to their school bags. We also give them little notes for them to take to their school, to their classes, to explain why they have got spectacles. And managing a child's emotion may come up after they start wearing spectacles because they were made fun of in class. And this point is very much missed, is that they are made an example of poor health habits by other parents. So when they go to the park, another parent will be like, see, if you see too much TV, you will land up like him. See, if you don't have your vegetables, you will land up like him. So they are made an example of poor habits by other parents, and made a point of worry for their parents and grandparents, and they overhear someone talking about his or her eye conditions, and that is managing the child's emotions. The next step is parental counseling, and this is again where you can stand out in your own practice, which is by making myopia clubs or myopia awareness meetings. We in our clinic have monthly meetings between all high myopes, everyone on atropine eye drops. So we have meetings for them. We have picnics where we give out frisbees, and also helping them to have more outdoor time, having movies and storybooks with main characters wearing spectacles, talking to school teachers, having talks in schools, as well as YouTube and social media awareness campaigns that you can do, all part of sharing with new myopes. You can share all of these tools, and the reason for that is fairly simple, very effective. And so now we move on to the next thing, that a parent of a new myope will say that, should I stop seeing TV and mobile forever for my child from today? And these are the various studies and these are the various guidelines that are there for TV and mobile watching. The next very important thing is, should I get blue light filter glasses for my child? Again, very much media driven, but these are 2 studies that I like to explain to them. One of them is a 1-year follow up, which has clearly shown that there is no significant advantage in terms of refractive power or axial length progression if you wear blue light filter glasses. But there is an improvement in 3 things if you wear blue light filter glasses, that is in the amplitude of accommodation, in the accommodative lag, and in accommodative sensitivities, especially in bright lights. So these are certain conditions where I suggest blue light filters, especially after sunset. The other study, which is very interesting, which is from LV Prasad, which actually says that wearing blue light filter glasses can potentially increase your myopia, because blue light, specifically the wavelength exposure, actually controls the axial length and inhibits the axial elongation in human eyes. They've done this study in human eyes. The next is myopia and outdoor sunlight time, already beautifully covered by our previous speakers. But the why and the how both need to be explained very importantly. And here is just one thing that I would like to say, that they can go out in the morning, evening, or afternoon. They can do their homework and family lunches in the balcony. They can have weekend outdoors. They can go in cloudy lights. They can wear a hat and go. Don't wear sunglasses and not gazing directly at the sun. And the next management option is, of course, showing them the myths and mindsets around carrot eating and vitamin A, also myths and mindsets around candle gazing and other eye exercises, and educate them about outdoor sunlight time. What I like to do at this stage is not talk about myopia drops on this setting, because the minute we mention myopia drops, they love the idea of myopia drops and stop taking the very important messaging of outdoor sunlight time. The next management option is treating the adjuvant problems being strabismus and amblyopia. So lots of studies have been done with myopia and amblyopia and myopia and squint. And these are topics that we want to cover at the new myopia level with our patients. And the last slide is, of course, this is the stage where we want to check for all pre-myopes in the family, already discussed by our previous speakers, how important genetics is. So this is the time you want to counsel them to check all siblings and all cousins. Thank you for your valuable time.